करते हैं सर. Good evening to all. Myself, Dr. Ashish Singh, member Pharmalok and Director Buddha Institute of Pharmacy, Gorakhpur. On behalf of Pharmalok, supported by APTI, Solution Pharmacy and Pharmatutor, I extend a warm and respectful welcome to each one of you today, Faculty and Student Development Program on enlightening theme, advancing pharmacy practices across hospital, community, and clinical settings. We are honored to have your presence as we gather to explore the evolving landscape of pharmacy practices. Now, it is my honor to introduce our speaker in brief. Professor Gir Sir is a senior faculty member in the Department of Pharmaceutical Sciences and Director, University of Kashmir, with over 23-year teaching and research experience. He has completed his master in pharmacology from Rajiv Gandhi University of Health Sciences, Karnataka, and his doctorate in the same subject from the University of Kashmir. Professor Geese had earlier served as coordinator of UGC Human Resource Development Center and director of the Center of the Career Planning and Counseling at the University of Kashmir, where he has organized numerous faculty development programs, including orientation and refreshment course, campus placement drives, and coaching programs for competitive examination. Known for his public speaking skill, popular sciences, column in local newspaper, Professor Gir is a prolific writer and ardent orator of the more than 125 popular science article and more than 200 extended lecture having been delivered outside his department. He has published 53 original research articles in the reputed national and international journal of reputed. Professor Geer has reviewed more than 60 research papers for high-impact international journal, has co-chaired around 50 scientific sessions in various conferences and seminars. Sir, his research team has earned 7 Best Research Paper Award, and his expertise in frequently sought in policy making, academic reform. Professor Gir sir is also actively engaged with several state and national level committees, serving as advisor to the Prison Monitoring Resource Unit, member of the UG and PG Curriculum Committee of the Pharmacy Council of India, member coordinator of NAC peer team, and CPCSEA nominee. He has been instrumental in shaping vision document and policy paper related to scientific research, higher education, pharmaceutical care services, state drug and procurement policy, universal health coverage policy, IPR policy, and the policy for implementation of NEP 2020. His area research interest including drug utilization evaluation, national pharmaceutical policy, pharmacovigilance, and relation use medicine. With great respect, I invite Professor Green to deliver his expert talk on the topic Advancing Pharmacy Practices Across Hospital, Community, and Clinical Setting. Sir.
Thank you. Thank you very much, Dr. Ashish Singh ji, for that very kind introduction. A very good evening to all of you. First of all, I would like to thank the organizers for inviting me to deliver this talk today on this faculty and student development program. And in particular, I would like to thank Mr. Amit Jha ji for all his efforts for upliftment of the pharmacy profession. Kudos and salutations to him for his spirit, for his endeavor, relentless efforts to promote the pharmacy profession throughout India. He has been a great leader in pharmacy in this direction. And the topic that has been assigned to me today to discuss in this faculty and student development program is advancing pharmacy practice, hospital, community, across hospital, community, and clinical settings. So this is the topic which has been assigned to me. for deliberation in this particular faculty and student development program. And I would request all the participants to mute their mics so that there is no disturbance or interruption. Right. So the slideshow is visible, Dr. Ashish Singh ji? Okay.
Yes, sir.
Right. So I'll be discussing, the topic which has been given to me by Mr. Amit Jha, advancing pharmacy practice across hospital, community, and clinical settings, with special emphasis on medication review, patient counseling, vaccination roles, collaborative healthcare. And in this topic has been given to me by the organizers itself, but I have added one important aspect, that is Pharmacy 4.0. Which is in sync with Industry 4.0. Nowadays, there is a lot of talk, a lot of buzz about Fourth Industrial Revolution, Healthcare 4.0, Industry 4.0. So I was just wondering whether anybody has ever talked about Pharmacy 4.0. So I thought, I couldn't find any resource material on this, any PPT or any lecture or any article on this, on the scientific literature. So I thought, let me make this beginning and start talking about Pharmacy 4.0. So I will be, informing the students what this Pharmacy 4.0 is all about, which is in sync with Industry 4.0 and in the Healthcare 4.0, and how we have to prepare ourselves for the Viksit Bharat at the rate of 2047. How the pharmacy professionals can contribute towards this lofty dream of Viksit Bharat 2047. Because we have already completed our Azadi Ka Amrit Kal after completing 75 years of independence a couple of years ago. Now we have entered the Azadi Ka, this Amrit Mahotsav we have completed. And now we have entered the Azadi Ka Amrit Kal. That is wherein we have to do Amrit Kal Vimarsh. We have to deliberate, discuss, do introspection, and find out ways and means how we can contribute significantly towards this important goal of Viksit Bharat at the rate of 2047. So for this, our pharmacy also has to gear up, and we have to impart skill and competency-based education at our educational institutions. We have to undertake cutting-edge, contextual, transnational research. We have to invest and promote innovation, incubation, startup and entrepreneurship development in pharmaceutical and medical sciences. Then only we will have healthy people who could contribute towards the goal of Viksit Bharat by the year 2047. So we have to take all the three fields together simultaneously. We have to start working in all these fields of education, research, innovation, incubation, and entrepreneurship development. Then only it will be possible for us to significantly contribute towards this goal. And, in this direction, just a minute. I'll just share my slides once again because the slides are not moving. They are getting hung up. I'll just share the slides again. All right. So in this, I will keep the slides in this mode only, because when I go to the slideshow mode, the slides are getting hung up, maybe because of some bandwidth related issue. So, but I hope these are visible. So first we need to, when we talk about Pharmacy 4.0, that means there must also have been Pharmacy 1.0, Pharmacy 2.0, Pharmacy 3.0, which has landed us into this new era of Pharmacy 4.0. So what is the evolutionary timeline of this Pharmacy 4.0? If we divide it, categorize it into several into several segments or compartments, we come to know that Pharmacy 1.0 started from ancient times till early 20th century, that is before 1940s, and which was the era of traditional compounding pharmacy, wherein the pharmacists prepared medicines by hand, by compounding, and they used natural products, botanicals, minerals. This is the era of the apothecary style practice. There was no industrial manufacturing happening, and pharmacy as an art of preparation was being practiced rather than the clinical science. Then came Pharmacy 2.0 from 1940s to 1980s, which was marked by the industrialized and product-centric pharmacy, wherein there was emergence of pharmaceutical industry and mass drug manufacturing. There was antibiotic revolution, vaccines, small molecule drug discovery. Pharmacists shifted from compounding to dispensing ready-made products. Regulations and quality standards were enforced through GMP, through pharmacopoeias. They were strengthened, and community and hospital pharmacy was mainly supply focused. And then the third era was the Pharmacy 3.0, which occurred between 1990s to 2010s, which was the era of clinical pharmacy and patient-centered pharmacy, and which was marked by the rise of clinical pharmacy, pharmaceutical care, medication therapy management, evidence-based practice, pharmacovigilance and drug safety systems, expansion of pharmacists' roles in immunization, chronic disease management, introduction of electronic records, early digital tools. Focus shifted from product to patient outcomes. And now from 2010 onwards, we have landed into Pharmacy 4.0. That is, this will continue at least till 2030. And probably in 2030, we will transition to Pharmacy 5.0. This Pharmacy 4.0 is marked by the digital era, digital transformation, intelligent and integrated pharmacy, wherein there is integration of artificial intelligence, big data, Internet of Things, robotics, blockchain technology, digital therapeutics, smart pharmacies, robotic dispensing, automated inventory, telepharmacy, e-prescriptions, virtual consultations, and a lot more. So we need to know, our pharmacists, our students, our teachers need to know what are the digital transformations that might happen in future, which are happening at present, and how we have to equip ourselves to face this new digital era of Pharmacy 4.0, and how we have to gear up for this particular challenge. Just a minute. So, when we look at now, the today's topic is advancing, pharmaceutical care, advancing clinical, community, and hospital pharmacy. We have to advance the pharmacy practice. We're talking about the pharmacy practice. Those pharmacists who practice pharmacy are known as pharmacy practitioners. Just like we have the medical practitioners, dental practitioners, nursing practitioners, public health practitioners, we also have pharmacy practitioners, which are the people who practice pharmacy. And pharmacy practice has three divisions: clinical pharmacy, hospital pharmacy, and community pharmacy. Clinical pharmacy is within the ward as well as in the OPD, when the pharmacist is directly dealing with the patient, giving him medication management advice and managing his medication therapy, monitoring him for adverse drug reactions, monitoring him for therapeutic drug monitoring, and that is clinical pharmacy. Community pharmacy is a place where there is interface of pharmacists with the patients, and that interface, that interaction could happen either within the hospital or it could also happen outside the hospital. So therefore, this is known as community pharmacy. Retail chain of pharmacies comes under community pharmacy. And then there is hospital pharmacy, which includes the administrative pharmacy, the hospital pharmacy department of a hospital, wherein they have to take care of the selection of drugs, procurement of drugs, their tendering, their estimation, their quantification, then their storage, their distribution, and their use by the patients, and their quality control. So everything is taken care of in hospital pharmacy. So hospital pharmacy has a staff, it has budget, it has infrastructure, they have to manage the educational programs and all. Everything comes under hospital pharmacy. Then there are other aspects of pharmacy also, like the industrial pharmacy, wherein we have people working under production, quality control, research and development, packaging, marketing, regulatory affairs and all. And then we also have the academics, wherein we can teach pharmacy or we can do research. And we also have CROs, the clinical research organizations, which conduct clinical trials, clinical research. So these are various areas, but there is one common thing in all of these areas, that the pharmacists who pass out from various pharmacy colleges, the pharmacy graduates, it is observed that they are being paid very meagerly. Am I audible? Am I audible clearly? Okay,
Yes, sir.
okay. There was some
Audible.
disturbance, right? So please let me know in case I am not audible or my slides are not visible. So overall, when we see that there are, the pharmacists are being paid very lowly. This article in Indian Journal of Pharmaceutical Education and Research, published few years back, highlighted how much they are being paid. In industry, around 8,000 rupees. In academia, between 10 to 15,000. Even PharmD graduates are being paid around 20,000. And in as medical writers, maximum 20,000. Medical coding, maximum 18,000. In clinical research, as coordinators or associates, they are paid around 22,000, and clinical pharmacists are paid around 10 to 15,000. What this is a very, this is peanuts. Now, like, nothing can be done within 10, 15, or 20,000s in current contemporary times. In this time and age, it is very, very less for a professional like a pharmacist who has spent 4 years in graduating from a pharmacy school. But why is it happening? The question is, why is it happening? It is happening primarily because our pharmacists do not have the required set of skills and competencies which is needed by the industry, which is needed by the academia, by research organizations, and by other institutions. So we need to upgrade our skills, competencies, our knowledge. We need to upgrade. There has to be a continuous need for learning, unlearning, and relearning. And we have to subject ourselves to a continuous process of skilling, reskilling, and upskilling. This has to be done on a continuous basis. This skill building has to continue. It is a lifelong process. It is a continuing process which has to be added with digital inclusion. So this continual evolution of pharmacy graduates has to be take place with reinforcement and advancement of their capacities and supporting continuous learning as employees increasingly chart highly varied courses. So this recycling has to be done. We have to give them necessary skills which are in demand. For that, they will get highly paid. The industry will seek after them, and they will find them and they will employ them. But provided they have the requisite skills and competencies, digital skills, IT proficiency, language proficiency, communication skills, hard and soft skills, life skills, leadership qualities, problem solving skills. All of these skills are required in contemporary times, but our pharmacy graduates don't have it. That's why when pharmaceutical industry goes for recruitment, anybody is ready to work for even 12,000 rupees. So why should they pay more? Because there's a huge crowd of pharmacy graduates who are willing to work at any salary, and they don't have any special skills. So only those who have special skills and competencies will stand out, and they will be in huge demand, and industry will look for them, and they will pay them in a handsome manner. So what skills do we need to inculcate among our pharmacy graduates in order to make them this industry ready, in order to make them future ready, in order to make them job ready? So already in this International Pharmaceutical Federation, which is a federation of all pharmaceutical organizations worldwide, more than 158 pharmaceutical institutions and organizations are its members, and it has a workforce of more than 4 million pharmacists are registered with International Pharmaceutical Federation worldwide. It has set certain pharmaceutical workforce development goals, and they have categorized those goals, those competencies or skills, into three groups. One is the competencies required for pharmacy practice, which is when you go to the hospital, clinical settings. Then second set is the competencies and goals to be fulfilled by pharmaceutical scientists who choose to do research, scientists who choose to do science and research. And then third group is those who teach in pharmacy colleges, this education workforce. So they have categorized these goals into these three categories. And initially, a set of 13 goals were prescribed by the International Pharmaceutical Federation in the year 2016 in accordance with the WHO guidelines. But then in 2020, they increased these goals to 21 and made them synchronize with the UN, this Sustainable Development Goals. So it includes all sorts of skills and competencies which have to be acquired by pharmacy graduates, whether it be the academic skills, research skills, leadership qualities, problem solving, professional development skills, then working with others, socializing. And then it also includes medicine expertise, people-centered care, expertise in communicable diseases, antimicrobial stewardship, patient safety expertise, digital health information and knowledge, and sustainability in pharmacy. So they have increased these goals to 21 in number in the year 2020. So we need to follow these goals. We need to see whether we are achieving these goals when we impart pharmacy education in our pharmacy colleges. To what extent we are doing justice with these goals. Now, when we look at the conventional roles and responsibilities of a clinical pharmacist, what are the traditional conventional roles? Right from the time when I graduated, there was some work being done in these areas in the pharmaceutical institutions. That is, pharmacists were being trained how to do drug utilization studies, how to undertake adverse drug reaction monitoring, therapeutic drug monitoring, how to undertake patient education and counseling, how to offer drug information services in hospitals to doctors, nurses, and other healthcare workers, how to monitor medication errors, how to evaluate prescribing practices, how to monitor drug, food, and drug herb interactions, how to undertake pharmacoeconomic and cost analysis, cost effectiveness, cost benefit, cost utility analysis, how to do pharmacovigilance in drug and undertake drug surveillance for safety, and how to utilize pharmacogenomic knowledge for safety assessment, how to utilize pharmacoepidemiological models and theories and procedures for evaluating drug use. These were the conventional, traditional roles and responsibilities. But with the passage of time, the roles and responsibilities of a pharmacist have evolved in India. And from original focus on medicine supply, it has moved towards a more inclusive focus on patient care. Now the pharmacist has moved from that of a compounder and supplier of drugs to that of a provider of pharmaceutical care. Pharmaceutical care is complete responsibility of the medication management, therapy, and prevention of adverse drug reactions and ensuring safety. Then, in order to prevent, detect, and monitor and resolve any drug related problems and adverse drug reactions, pharmacists have been trained. Their role is very hugely appreciated. Then, pharmacists also have to decrease the burden of 5 Ds, that is, death, disease, discomfort, disability, and dissatisfaction. This is the ultimate goal of pharmacy practice. We have to decrease the burden of these 5 Ds, and then only we will emerge as a 7-star pharmacist. This was the flagship scheme, this floated by the International Pharmaceutical Federation early 2000, and then adopted by the Indian Pharmaceutical Association also. Then this 7-star pharmacist means to become a caregiver, a communicator, a decision maker, a teacher, a lifelong learner, leader, and a manager. And the focus of a pharmacist is now moving from product to patient, from bedside to bedside. For years, for decades together, we have been working to produce pharmacists for the industry who are well versed with the product, with tablets, capsules, syrups, injectables. But now the focus is moving towards the bedside, towards the patient, wherein pharmacist would be equal partner of an healthcare team, and he will contribute significantly towards the well-being of the humans, well-being of the patients. And now coming to pharmacy 4.0. So we have seen what were the conventional, traditional roles of pharmacists over the last several decades, maybe 2-3 decades, and how it has changed into new roles. But now, what are the emerging new frontiers, new challenges, and new vistas in pharmaceutical sciences, which we need to acquire, which our pharmacy graduates need to inculcate in their curriculum, in their training. They need to know about these emerging new frontiers, which will land them into the pharmacy 4.0, and we will prepare them for pharmacy 5.0. Then only we will become significant contributors towards the goal of Viksit Bharat by the year 2047. And these emerging areas are pharmacovigilance, materiovigilance. First, I will read them out, then I will discuss them one by one. Cosmeticovigilance, hemovigilance, herbovigilance, immunovigilance, and nutraceutical vigilance. Then we need to train our graduates in personalized and precision medicine. We also need to give them a good, fair amount of knowledge about holistic, integrative, and lifestyle medicine. And then there is advent of this telepharmacy and bioelectric medicine, which we have witnessed how telepharmacy proved to be very useful during COVID-19. And the new emerging these techniques, the genoinformatics, bioinformatics, immunoinformatics, chemoinformatics, toxicoinformatics, and pharmaco. What are all these? How many of our students know about these new techniques? Similarly, how many of students know about pharmacogenomics, transcriptomics, proteomics, microbiomics, or pharmacometabonomics? In the coming era, the drugs are going to have a very little role, and major role will be played by stem cell therapy, gene therapy, genetic engineering, as we have witnessed in CRISPR technology, CAR T cell therapy, how it has changed the face of medical therapy. And then there is the equity and this equality in healthcare through pharmacoeconomics, health outcomes research, and also through pharmacometrics, this prediction analysis, simulation analysis, PKPD modeling. And what will be the role of artificial? Nowadays, we are hearing a lot about artificial intelligence, machine learning, how it will affect the pharmacy profession, how it will affect the research and development in pharmacy, pharmaceutical formulations, drug utilization, drug distribution, and what will be the role of nanomedicine and nanodiagnostics, how big data analytics and clinical data management is going to change the face of pharmaceutical education and research in future, and what will be the role of 3D printing and robotics, how functional medicine will be very important, translational and regenerative medicine will assume importance, how clinical research organizations will be changing digitally, transforming themselves, and using knowledge process outsourcing in complete digital format, and what is the emerging, evolving role of biosimilars and biopharmaceuticals. So these are the emerging new frontiers and vistas in which we need to teach our budding pharmacy graduates and postgraduates. We need to give them adequate training in these areas. So in my topic today that has been assigned to me, I have been told to discuss about vaccination roles and collaboration with other healthcare workers. So when we talk about vaccination roles, the COVID-19 comes into our mind when pharmacists played a very pivotal role in identifying the patients, in vaccinating them, in ensuring social isolation, social distancing, in going from home to home, house to house, and marking the patients and identifying them, vaccinating them, and then arranging cold chain storage for these vaccines. So pharmacists have played a very significant role, and that needs to be fostered and harnessed further by giving them training in administering vaccines, the various types of vaccines, how to administer them, how to screen and assess immunization needs, how to prepare the schedule of immunization, vaccination schedule of infants, and how to educate the patients and healthcare teams about the importance of vaccines, safety. Of many people have many myths about vaccination. Some people think that COVID-19 vaccines may cause adverse effects or may harm in the long run upon chronic use or upon long term, but which were myths which need to be allayed and apprehensions which need to be allayed by the pharmacists. And we need to train our pharmacists in managing how to maintain cold storage, how to maintain inventory, and how to maintain good documentation of vaccines. We also need to coordinate and communicate with other healthcare workers, for other public health officers for immunization programs. We can also participate in framing policies for various immunization programs, and we can provide clinical decision support. Clinical decision support system is a very important system for taking clinical decisions, to which population we should give vaccines, or which population we should not give. For example, these days winters are approaching, so whether we should give influenza vaccine or not, which population is more vulnerable, whom to give, whom not to give, all that decision making has to be done, and pharmacists has to take part in that. Then monitoring safety and participating in immunization research, new vaccines, new immunization techniques, and new methodologies for population studies. That also has to be undertaken by the pharmacists. And when we talk about the role of a pharmacist in collaborative healthcare, pharmacist cannot work in isolation. He cannot work alone. He has to work in collaboration with other healthcare workers like doctors, nurses, technicians, paramedical staff, because he has to develop networking, he has to develop socializing these networks, and he has to continuously be in constant communication, constant loop with other healthcare workers. Then only we can have delivery of healthcare services in an integrated and seamless manner. So, pharmacist's role in collaborative healthcare comes from optimizing medication therapy, providing direct patient care, participating in interdisciplinary teams. For example, if you have to do pharmacoepidemiological studies, you form interdisciplinary teams wherein there is a doctor, a nurse, a pharmacist, a technician, an immunization worker, and all of them work in this. They work in unison and they work in an integrated manner. Then we need to educate patients, healthcare professionals about various diseases, about drug therapies, adverse drug reactions, about patient safety, and we have to ensure medication safety. We have to manage chronic diseases. Chronic disease is becoming an epidemic. This non-communicable diseases, chronic diseases like hypertension, thyroid disorders, obesity, cardiovascular diseases. This has assumed a lot of importance these days. So pharmacists cannot remain behind. He has to actually take part in all of these, and he has to support transition of care. Transition of care means when a person is moving from primary care to secondary care to tertiary care, when the patient is moving from one hospital to another. And this pharmacist has to manage and ensure this seamless transition by providing the necessary guidance, supervision, counseling, not only to the patients but also to the healthcare workers. So he has to serve as a bridge between two institutions, between two levels of care. And he has to serve on clinical committees for framing hospital formulary, for framing drug therapeutic committee, for essential list of medicine preparation, and for many other activities. He has to promote public health. He has to be an active worker in public health and engage in research and training. These are the collaborative roles of a pharmacist. Then nowadays there are a lot of progress is being made in developing new wearable gadgets. Some of the students who are interested in entrepreneurship can switch their gears and can take part in these entrepreneurship activities. They can take up business ventures because a lot of new devices are coming up which are wearable gadgets. For example, smart contact lenses for tear analysis of glucose, then earbud sensors for detecting stress levels, skin patches for monitoring blood pressure and other vital signs. Then even smart rings which can be worn in a finger for tracking sleep quality, stress levels, and oxygen saturation. Already we have these smart watches which are monitoring heart rate, blood pressure, and many other things. And there will also be smart textiles which can sense sweat analysis, which have nanosensors or biosensors that can do sweat analysis. Smart glasses can also have augmented reality integration. Smart glasses can have this Bluetooth, and they can, we don't need to wear these Bluetooth devices, and they can do the augmented reality integration. Similarly, virtual reality for mental and physical therapy, wearable ECG monitors, and portable handheld USG machines, wherein people can do their USG on their own. They don't need to go to the clinic or the hospital. And nanobots are used in many of these variables, which are tiny sensors that can track things like blood pressure, nutrient levels, glucose levels, and even fight off infections by administering drugs directly. So those of the students who are interested in startups, who are interested in entrepreneurship development, they can work in these areas. They can start doing business. They can start coming up with new ideas and having startups in these areas. But while there is need for convergence into these nano sensors, nanobots, and all, there is also need for divergence. Convergence and divergence has to happen simultaneously. Convergence means focusing at one small thing, one particular focus. But divergence means going broad, becoming widespread. And divergence will happen when we integrate with other systems of medicine. Collaboration doesn't have to be only within the allopathic system of medicine, but cooperation, integration, and collaboration has to happen with other systems of medicine also, like Ayurvedic, Unani, Siddha, homeopathy, naturopathy. We have to, why is it needed? For the sake of holistic medicine. Holistic medicine means, as of today, we treat a patient only when he has certain symptoms. So, in the pyramid of healthcare, this pyramid of healthcare, there are so many actions which need to be taken, so many services which need to be delivered. For example, disease prevention, health promotion, primary care, diagnosis, treatment, rehabilitation, and continuing care. But unfortunately, we have restricted our role only to diagnosis and treatment of disease. We are not, our pharmacists are not playing any part in disease prevention. They are not playing any role in health promotion, in primary care, in rehabilitation, in continuing care. But which is very, very important, because if we start treating patients only after they get symptoms, the treatment cost will escalate. It will be very high. We have to be proactive in healthcare. We have to start working right from the time a person is born, and we have to check his susceptibilities. That is the baseline risk. What ailments could he suffer from in future life? Then we have to do preclinical progression. We have to screen them, monitor them, whether they are, for example, pre-diabetes or pre-hypertension. So we have to monitor them for switching over to full-fledged clinical diabetes or clinical hypertension by doing continuous screening. Only then comes the diagnosis. When the person has got certain complaints, certain symptoms, we subject him to diagnosis. We check the prognosis of the disease, give him the treatment, and then the clinical disease and progression starts, which needs to be curbed. But the pharmacist has to start quite early. I'm asking a question: how long will our pharmacists restrict their activities only to dispensing of drugs, only to distribution of medicines? When will our pharmacists take part in promoting healthcare, in preventing disease, which we are not doing at present? So this is the right time when we can do all of that, because worldwide there is a this reconnaissance, and there is a consciousness, increasing level of consciousness about the perils of modern lifestyle. As you all know, that in modern lifestyle we have become sedentary. We are using excessive alcohol consumption, we are using tobacco, smoking, we are using processed food, people are using mobile phones, which has made them physically inactive and which is giving them less sleep. And there is environmental pollution also. All of this is leading to a host of cardiovascular diseases, cancer. It is leading to diabetes, stroke, osteoarthritis, respiratory diseases, the non-communicable diseases which I was mentioning earlier, chronic disorders, and for which drugs have to be taken for the lifelong. And when a person starts taking medicines for a long time, he experiences there are perils of modern medicine. While the modern medicine has been the panacea to save us from the ills, from the ailments, but at the same time, it is giving us certain new things, certain new discomforts, that is known as the perils of modern medicine. Like adverse drug reactions are there, medication errors, drug related problems, polypharmacy and irrational prescribing, drug interactions and allergies, non-compliance, non-adherence, self-medication and drug abuse, substandard and fake medicines, over-the-counter sale of prescription drugs, and irrational use of medicines. These are all perils of the modern medicine. So how we can overcome these perils or these disadvantages? By transitioning, shifting from passive to proactive health. We have to move from passive to proactive health. The service philosophy of healthcare has to change from patient-centered to people-centered healthcare. The service delivery, the service subjects, the service objects, all of it has to change. We have to move from disease-centered to health-centered healthcare. We have to move from passive to proactive healthcare, from curative or prescriptive to preventive healthcare. This is the model which is being adopted by China, and we also have to adopt it, because we cannot wait for a patient to have symptoms and complaints and then only start treating him. We cannot only concentrate on patients. Our healthcare has to be people-centered rather than patient-centered. That means we have to prevent disease, we have to promote health and wellness, and we have to be health-centered this in our approach rather than disease-centric. And we have to give preventive healthcare rather than only curative or prescriptive healthcare. So that will give us 6 kinds of new initiatives, new perspectives in healthcare. That is, we will switch over to preventive healthcare, promotive, personalized, precision healthcare, proactive healthcare, which includes self-rule and self-discipline. and co-construction and sharing between patients, between populations, between groups. That will make us more alert, more educated, more well informed about disease, and we will move towards wellness. We will not switch into disease, we will not transition towards illness, but we will remain aloof from disease. And this model is being adopted worldwide. People are becoming more and more conscious because of adverse drug reactions of medicines, because of other issues. So people want to stay away from disease. They want to be aware, educated, well informed, so that they could prevent disease and they could promote wellness in their lives. And this healthcare will become personalized. That is, we have a general healthcare, which is one pill for every ill, and we have one treatment for all the patients. But personalized is which is tailored to the individual needs of one person. So that will become possible only we take advantage when we take advantage of procedure, these genomic, transcriptomic, and other omic-based studies, omic-based technologies, and when we take care of the environmental factors, also epigenetic factors, then the pollution, the behavioral factors, personality-related factors also, then we'll be able to deliver personalized medicine. But for that to happen, we also need to take recourse in lifestyle medicine. What is lifestyle medicine? There are 6 pillars of lifestyle medicine. Only medicine cannot be of help. There, we have to tell the patients, we have to educate the patients about lifestyle medicine and its 6 pillars. Its 6 pillars are stress management, physical exercise, nutrition, healthy eating, avoiding risky behavior like use of tobacco and alcohol, then restorative sleep, positive social connections, social support, and stress management. So when we simultaneously work on these aspects, we reduce our stress levels, we take a full restorative sleep of at least 8 hours per night, we avoid use of risky substances like alcohol and smoking, we take adequate balanced diet and nutrition, and we resort to good social connections and social support. We also undertake regular physical exercise. We will stay away from disease. We will be promoting wellness. We will be promoting health. So pharmacist has to take part in these activities. Pharmacist has to get himself trained in this, and then he has to educate others. So these are the competencies which are to be inculcated in today's pharmacists. And all of us know that artificial intelligence is making inroads in every sector, and it is taking everything by its stride. So in healthcare also, we are not leaving behind. We cannot remain behind, because artificial intelligence will help us in early detection of disease, will help us improve decision making. It will help us in selecting appropriate treatment. It will help us in expanding access to medical services. People from home can access it. And it will also help us in giving a very superior kind of experience and checking health through gadgets, through wearables, and then also continuing care, end of life palliative care, rehabilitative care. All of them will be more accessible and available by the use of artificial intelligence. But when we talk of artificial intelligence, a lot of changes are happening, transformation is happening. At present, we are going through the era of artificial narrow intelligence or generative artificial intelligence, which is stage one, wherein we are making use of machine learning. Its scope is narrow and solutions are also narrow. But then will come the next stage, stage two of artificial intelligence, known as artificial general intelligence. This time we are going through the generative artificial intelligence, but then we will switch over to artificial general intelligence, which will be also be guided by machine intelligence. Instead of machine learning, we will shift to machine intelligence, and that will match human level intelligence. And then will come the third stage of artificial super intelligence, which is stage three, when there is machine consciousness, which is superior to human intelligence. The machines may become superior to human intelligence. Scientists have devised these 3 scales. I have not devised it. So it is they are predicting that we may go through this kind of journey in artificial intelligence. Therefore, we need to prepare ourselves. Already, machine learning is helping us out in analyzing data, in coming up with predictive simulations, in PKPD modeling, in pharmacometrics. Machine learning is helping us. What exactly is machine learning? See, if you watch some videos on YouTube or Instagram, the phone starts to give you the similar kinds of videos because it learns from your behavior, and then it comes up with it with the similar content. So that is machine learning. Similarly, if you have databases, the machine learns from the huge database of millions of people, and then it predicts certain things. It predicts the treatment, it predicts the this disease eruption, and then it gives solutions. So this machine learning could help in drug discovery, manufacturing, in outbreak prediction, in crowdsourced data collection, in clinical trials, in smart health records, and behavioral modifications. A lot of applications are there which machine learning will have, but we also need to integrate omics based technologies. We need to apply omics based technologies. So our pharmacists have to learn these if they want to be future ready, if they want to be industry ready, if they want to be well aware of the future changes, future challenges. They need to learn what is genomics, what is transcriptomics. Genomics is the full set of genes in a person. When we do gene mapping, we come up with genomics. The genes give rise to RNAs, DNA gives rise to RNA gives rise to proteins gives rise to metabolites. So accordingly, when we do full mapping, full of these genes, we come up with genomics. Could you request all the participants to please mute their mics? There is some disturbance from somewhere. And transcriptomics is the study of all of RNA in the body. Proteomics is the study or mapping of all the proteins. And metabolomics is the study or mapping of all the metabolites. Therefore, when we apply these to the study of pharmaceuticals, we call it pharmacometabolomics, pharmacogenomics. And similarly, it is very, very important to know the full mapping of microbiome in our gut, which affects the brain. Even it has has a connection with brain function, and it is very, very important in maintaining good health. Similarly, phenomics means what is the major and minor phenotype. Phenotype is the your physical, physiological, molecular, cellular characteristics. Exposomics means environmental exposures, which also through by way of epigenetics affects the gene expression. So exposomics is important, epigenomics is important. All of these omics-based technologies are very, very important, which we need to learn, assimilate, and integrate. And then the pharmacogenomics is basically of two types: structural pharmacogenomics and functional pharmacogenomics. Structural, wherein we do gene mapping, chromosome mapping, DNA sequencing, and small nucleotide polymorphism mapping. And under functional pharmacogenomics, we identify disease markers, we undertake linkage analysis, gene expression studies, drug target interactions. So we need to do these pharmacogenomics or pharmacogenetic-based studies, phenome-wide and genome-wide studies. Then we'll be able to develop a full biosignature of the human being. And that full biosignature means what all is happening inside the human body, how DNA is translating to RNA, RNA is getting leading to protein synthesis. That in turn is catalyzing various these biochemical reactions and producing metabolites. So when we know all of this, when we have full this computational and this computer-based information or database about genes, we call it genoinformatics, the genetic variations in mutation data. And we know about bioinformatics when we know about target discovery, pathway analysis, and biomarkers. And we also need to know about immunoinformatics, the immune response modeling, epitopes, how allergic reactions are caused, what are the various antigens and antibodies produced. Then chemoinformatics, we have to do molecular design, molecular modeling, pharmacophore modeling, quantitative structure activity relationships, and toxicoinformatics, the toxicity prediction, safety profiling of patients, and lastly, the pharmacoinformatics, that is this absorption, distribution, metabolism, elimination, PKPD modeling, drug interaction studies. All of these together are known as health informatics or clinical informatics. When we do all of these studies on informatics-based technologies, genomics-based technologies, we will be able to develop full biosignature of the person. Then we can develop his digital twins. And those digital twins can be used in clinical research, in prediction, simulation, in prediction of the disease outcome, drug therapy outcomes, and prediction of the treatment outcomes. So that is a very advanced level of technology which will become possible after we make full biosignatures using genomics and informatics based technologies. Then other areas in clinical hospital and community pharmacy are the interface between pharmaceuticals, herbs, cosmeceuticals, and nutraceuticals. We have all heard about pharmacovigilance. Pharmacovigilance is the study of adverse drug reactions, the study of drug safety, monitoring of medicines for their safety. But then, there is Pharmacovigilance Program of India. There is also Cosmetovigilance Program of India, wherein we observe, monitor the cosmetics for their safety, for their adverse reactions. Material Program of India includes the safety of medical devices. Even cotton, gauze, syringe, needle, they are medical devices. We should not only think in terms of medical implants or pacemakers. Everything we use in a theater or in the clinical settings, the instruments, they are all devices. So we need to monitor them for any adverse effects or events. Then hemovigilance, blood transfusions, their incompatibilities. Herbovigilance, the herbs and their safety, their adverse reactions. Immunovigilance includes the safety of vaccines and their adverse reactions. Nutraceutical vigilance includes the safety of nutraceuticals and any adverse reactions caused as a result of using them. Then we also have the pharmacovigilance at the industry level, at the corporate level. When we work in an industry, pharmaceutical industry, there we go for safety report writing. We go for signal detection, risk management, plant preparation. And we also do these continuing drug safety study reports. And we also prepare drug regulatory affair reports. We assign a qualified person responsible for pharmacovigilance. We do prescription audit, comprehensive clinical pharmacovigilance. So we have, in every pharmaceutical industry, we have drug regulatory affair department, we have pharmacovigilance department, which monitor adverse drug reactions, which compile them, consolidate them, record them, interpret them, analyze them, and then generate signals and maintain it in the form of a database. We might have heard about Vigibase, Vigiflow, which is maintained by the Uppsala Monitoring Center. We also need to impart sufficient training to our pharmacists in pharmacoeconomic-based studies, the drug utility, drug evaluation, drug effectiveness analysis, drug cost analysis. So there are direct costs and indirect costs. Direct costs as a result of the medicines, as a result of non-medical costs, for example, association with treatment but not due to medicine. Cost of transportation, food, lodging, that is non-medical. But medical is cost of drugs, cost of therapies, physician's cost. Then there are also indirect costs, which happen as a result of loss of earning, loss of business, or sale of assets. Intangible costs, which cannot be measured. Intangible means like pain, suffering, anxiety, inconvenience, difficulty to quantify. These are very difficult to quantify, but there are techniques in pharmacovigilance and outcomes research wherein we undertake cost-benefit analysis, cost-effectiveness analysis, cost minimization, and cost utility analysis. And we see what is the impact of cost on quality of life, whether the drug we are using or procuring is giving us the value for its money, and whether we are able to have good patient preferences, patient satisfaction after drug therapy. All of these are coming under pharmacoeconomics, which we need to teach, which of course is a part of the curriculum at master's level. And pharmacoepidemiology, the study of drugs in large populations. When we study, we use epidemiological models to study drug use in large populations. So those studies could either be population-based or individual-based. They could be randomized controlled clinical trials, RCTs, or they could be non-randomized observational studies. If we do population-based studies, again, they could be descriptive health surveys, or they could be analytical ecological studies. And the different types, different designs are there, like cross-sectional study, case control study, cohort study. Our pharmacists need to know, particularly the master's degree PhD students, what are these various designs of undertaking research in large populations. As I said, precision medicine is very important, which will lead to personalized medicine. In traditional medicine, we have a group of patients to whom we are giving the same treatment to all the patients in this group. So they will have adverse effects. Some of them may have no benefits, some of them will have benefits, because we are giving one drug to all the patients if having the same disease. Then stratification is done under stratified medicine, wherein we are dividing these patients into several groups on the basis of their demographics, socioeconomic factors, on the basis of biomarkers or other subpopulation characteristics. Then we are giving one group we are keeping as a patient, and another group we are giving different drug. So patients groups may benefit from more targeted treatment. This is known as stratified medicine, where the treatment is more targeted. Group patients are divided into groups, and then we are giving selective therapy to each group. But when we give at the individual level, we call it precision or personalized medicine. The drugs are tailored to the individual needs of a patient on the basis of his genomic studies, omics, and informatics studies, on the basis of his lifestyle, health history, medical records, compliance, and other environmental factors. We select one A drug therapy for one person, B for another, C for another. So different drug therapies for different individuals, and each patient will benefit from individualized treatment. Less side effects will be there, less treatment failures will be there. And translational medicine is also very important. When we do some studies on animals, the preclinical studies, which is the basic science research, we try to work on the mechanisms, the targets, and lead molecules, but it has to translate to benefit to humans. We have seen that in our universities and in our colleges, we do a lot of research on natural products, on plants, but that never translates to actual benefits to humans. It never translates into some kind of therapy or formulation for humans. So there has to be a proof of concept in phase 1 clinical trial, and new methods of diagnosis, treatment, and prevention have to be found. Then we move to phase 2 and 3 of clinical trials, wherein we undertake controlled studies leading to effective care. Then translation to practice, that is phase 4. The new drug application has been filed and clinical trials have been completed. And now we go to the post-marketing surveillance and major clinical outcomes. So delivery of recommended and timely care is to be ensured to the right patient. Then translation to the community, the population level outcomes research, epidemiological studies, pharmacoepidemiological studies, which will translate into true benefit to the society. This is what translation medicine is all about. Our students need to be taught about this translational medicine, wherein the basic science, the evidence generated through basic science has to translate into some kind of practice and some kind of policy. And then it has to translate to benefit to the patients, benefit to the populations. That is translational medicine. Similarly, we need to gain sufficient knowledge, sufficient skills and competencies about pharmacometrics. In COVID-19, when there was no time to do clinical trials for several years, clinical trials were completed within months, and we had to resort to simulation modeling, PK/PD modeling. We had to resort to pharmacometrics. That is wherein you do these dose individualization, you undertake pharmacogenetic-based studies, and you optimize doses, and you simulate based on the effects observed in a population group. You simulate the effects in another population. And you do PK/PD modeling, physiologically based PK/PD modeling. You do molecular modeling, pharmacophore modeling and analysis, and you do most of the things on computer-based drug design. And then you come up with certain data, the dose, the adverse effects. Machine learning is a very high value in this, because you generate evidence from millions of people through databases, and that helps you in coming up with certain new therapies. Similarly, we need to have sufficient knowledge about nanomedicine, because without nanomedicine, we cannot live in the coming era, because nanodiagnostics are making inroads in vitro and in vivo techniques. Medical imaging is incorporating nanotechnology. Nanotherapeutics are being, new therapeutics are being designed and developed. Nano vaccines, and they are also, proving helpful in regenerative medicine and biomaterials. And there are different types of nanomaterials that can be used for nanomedicine. They could be carbon nanotubes, metallic nanoparticles, liposomes, quantum dots, silica nanoparticles, dendrimers, and then myceles or drug conjugates. We need to know what all of these are, what are their applications, how they are synthesized, how they are characterized, and how they are utilized. So our students need to be given this kind of training in nanomedicine. And we have recently observed in, this is the future of healthcare. That is, we may not be using medicines anymore in future. Rather, we'll be doing genetic editing, the gene editing, as we have witnessed in CRISPR-Cas technology. This CRISPR-Cas technology was developed initially in 1987. It was described in 1987, and since then, a lot of progress has been made. And very recently, we have found that Cas9 RNA mediates site-specific genome engineering in human cells, and other eukaryotes. So genetic editing is the future. Wherever you find any polymorphisms, SNPs, you remove that gene, cut it out, and the person becomes less vulnerable to that disease. So genome editing will be the future of drug therapy. And also CAR T cell therapy has made a lot of progress. Recently, cancer treatment in one specific type of cancer became possible due to CAR T cell therapy, wherein chimeric antigen receptor T cell production and infusion is done. This is the procedure. You collect the blood from the person, then you isolate T cells, reprogram T cells from the blood of that person, and then you energize them, you stimulate them, and convert them into CAR T cells. Then you allow them to propagate and multiply, and then you inject it back to the same person. Now the same CAR T cells attack the cancer cells. So these T cells are isolated from the patient's blood, and new gene encoding receptor is incorporated into these T cells. Then these genetically engineered T cells are specific to a specific desired target, and they are injected back. And when they are injected back, they start attacking the cancer cells, specific type of cancer cells. And that's how the treatment becomes possible. And a lot of old drugs are being repositioned, and they are being these old drugs are being repurposed for new uses. And this drug repurposing or repositioning is of three types: profile-based drug repositioning, network-based drug repositioning, and data-based repositioning. Profile-based drug repositioning uses bioactive profile of a drug in tandem with other drugs or disease profiles that can be categorized as expression profiles. And network-based approach combines information regarding drugs and their targets obtained from various databases and predicts potential drug candidates. Similarly, data-based approach uses electronic health records on the clinical history of the patients, which includes the results of laboratory tests, drug prescription data, symptom description, and image data. And similarly, there are several examples of such drugs which have been repurposed or repositioned. For example, the sildenafil citrate, for the drug used for impotence. Original indication was for hypertension and angina, but later on it was repurposed for erectile dysfunction, pulmonary hypertension among children. Similarly, thalidomide, which caused the thalidomide tragedy way back in 1960, which was initially developed for sedative, use as a sedative among pregnant women for preventing morning sickness. But later on, due to thalidomide tragedy, the malia and short limbs of newborn babies, it was abandoned, it was banned. But now it is being repurposed for multiple myeloma in leprosy. Similarly, minoxidil, the drug used in hypertension initially, but now is being used for alopecia. Metformin, which was actually an anti-influenza drug, and it has proved to be a blockbuster drug in type 2 diabetes mellitus. Remdesivir was initially developed for hepatitis C, but used in COVID-19. Aspirin was analgesic and antipyretic because of gastric bleeding and blood thinning. It was repurposed for cardiovascular protection and stroke, prevention of stroke, heart attack. Bupropion was initially developed for depression, but used for smoking cessation, attention deficit hyperactivity disorder. Duloxetine was developed as an antidepressant, diabetic neuropathic drug, this prevention of diabetic neuropathy, but was used for citrus urinary incontinence and fibromyalgia. Similarly, auranofin was developed as a disease-modifying anti-rheumatic drug, for treating rheumatoid arthritis, but was found useful in giardiasis. This is how old drugs are repurposed, repositioned based on their new activities, and all many of you can do research in MPharm on repurposing and repositioning of these drugs. The role of data mining is important. In now in present age and times, a person who owns the data owns the everything, and data is the new capital, data is the new currency. One who has the data is the king. So we need to know how to analyze, how to utilize this data. What are the various data mining approaches? What are the various Bayesian neural network approaches which can be used by collaborating, by coordinating it with artificial intelligence tools, by using cloud computing platforms, by using blockchain technology and machine learning models? How we can utilize this data which has been collected through electronic health records, through registries, cancer registries, or through biosensors, or through these post-marketing surveillance, or through databases, and how we can utilize that data in predicting disease, in predicting effectiveness of treatment, in predicting adverse reactions. That is very, very important. And data, that is what machine learning does. The machines learn from the data of millions of people and come up with the predictions for the new people. Similarly, this clinical data management is a new science, new technology, new technique which is being taught in the colleges, because a person who knows how to manage clinical data can be in high demand. He will be paid handsomely in any industry. He should be aware of data extraction and archival procedure. He should know about database locking, medical coding, discrepancy management, data validation, data cleaning, data entry, data collection, data designing, and finalization of study documents. So if you have these competencies, if you have these skills of how to collect data, how to clean it, how to record it, document it, how to validate it, how to utilize it, you will be in high demand in the industry. And same is the case with medical writers, medical coders. For example, when you have lots of prescriptions, you have to code it into information which is good for insurance agencies. The insurance companies need data on their own prescribed format from the prescription. So you have to code it and decode it. That is where medical writing comes into practice. And medical writing also includes developing outlines, drafts, promoting content on social media, attending meetings, performing literature search, and ensuring quality control. There are a lot of activities under medical writing. So you can undertake a course in medical writing and you can develop these skills. Again, you will be in high demand and you'll be paid very well by the industry. Then telepharmacy has assumed importance in COVID-19 when the patients were working, sitting at home, doctors were working from home. Only thing which was connecting them was the internet, was the telepharmacy. So through telepharmacy, the patients were being tested, diagnosed, they were being evaluated and assessed, they were being treated. So this has come up in COVID-19 and it will grow further because, with the advent of these wearable gadgets, when a person, there is a lab on the chip technology, the person can do all the diagnostic tests by himself at his home. Then he can also check what are the possibilities of diagnosis and he can see what are the treatment options available to him. Only thing he needs is a small consultation from the expert, from the doctor, who will guide him towards the right therapy. So most of the things a person will be able to do at his home. So you need to know this telepharmacy, how medication orders are reviewed, prescribed, they are collected, how they are dispensed, how medications are delivered, how medical reconciliation is done. What is essential, what is not essential, what needs to be kept, what needs to be removed. That is reconciliation. And how medication optimization, which drug is better, which option is better. For example, this pregnant lady is suffering from hypertension. Can we give calcium channel blocker or beta blocker or thiazide diuretic? No. So which drug will be effective and with least adverse drug reactions in her? So medication adherence assessment, medication drug monitoring, drug-drug interaction monitoring, chronic disease management, particularly in elderly patients, pregnant ladies, children. Then also conducting patient awareness, education programs, and psychological support, mental health support, giving drug information services to doctors, to nurses, to other healthcare workers. All of this can be possible through telepharmacy. So we need to know, our students need to know what is telepharmacy. Our students also need to know what is bioelectric medicine, electroceuticals. You have heard about pharmaceuticals, you have heard about cosmeceuticals, but have you heard about electroceuticals? Electroceuticals are small doses of electrical impulses which neurologists give. For that also you have to do dosing, you have to do target identification, and molecular biologist will identify the target of a disease. Then the neuroscientist will identify the neural pathway, how to deliver that small impulse of current, and will manipulate the target. They can target could be the cell, the tissue, the receptor, or a nerve. And the devices will be used for delivering these short electrical impulses through implants, through these transdermal patches, or through other electrical devices. Engineers will develop those devices, computer scientists will manipulate or modulate those. And that is what bioelectric medicine is all about. Bioelectric, why do we call it pharmacy? Because you are giving small doses of electrical impulses as a treatment therapeutic purpose, and you have to manipulate them, calibrate them, modulate them appropriately, so that there is no excess of electrical therapy, there is no damage caused to the cells, tissues, organs, or receptors, or molecular mechanisms, and only the right dose is delivered at the right time and right place. For example, people suffering from Alzheimer's disease, stroke, epilepsy, and Parkinsonism, they have found to be effective. These therapies have been found to be effective in such patients. So our students need to know what is bioelectric pharmacy, what is reverse pharmacology. Generally, the clinical trials take several years, but when you do it using reverse pharmacology process, it is finished within 5 to 6 years. And in that, what you do is you first analyze the databases. From the databases you do the lead identification. From computer based drug design, computer aided drug design, you do the lead identification, target identification. Then you switch over to lead optimization, target validation. Then you do molecular modeling, pharmacophore modeling, and then you do in vivo and in vitro. And then you switch over to clinical trials, and then you see the effectiveness, safety, and toxicity of the lead identified. So that way, when you have the leads in place at the very beginning, you don't have to go and search for the leads. So leads means those molecules which are effective, and target means the receptor. So this is done through reverse pharmacology. Less time is consumed, less money is needed, and clinical trials are hastened by this process. And nowadays, when somebody loses a limb, or somebody loses a cartilage, or somebody loses a muscle, or there is need for regenerative medicine, the medicine which can regenerate that lost, degenerated, deformed tissue in a bone, in a cartilage, in skin, or even in muscles or myocardia. So for that, stem cell therapy is used, the platelet-rich plasma is used, and lipogems and prolotherapy is used for regenerative medicine. That is, it becomes possible to regenerate the lost tissue, degenerated, deformed tissue, and a lot of progress is being made. Already the bone has been regenerated from nanoscaffolds, and 3D printing is coming up like anything. We need to know what is 3D printing, how it is done, what is the various flow process in this, right from the stage of ideation to modeling to slicing and printing, how these 3D printed material, it could be a tissue, it could be an organ or a cell which is being 3D printed, and it could be based on microdosing without oxidation. So that 3D printed molecules will function exactly in the same manner as the original tissue or organ. And a lot of progress is expected in the coming times in this technology also. So these are the several technologies which our students need to know in order to have adequate pharmacy practice knowledge, skills, and competencies across the domains of clinical, community, and hospital pharmacy. And to conclude my talk, I would say that our students need to acquire optimum knowledge, skill, and competencies in pathophysiology of disease. We need to have good knowledge about pathophysiology of disease, good knowledge about applied pharmacotherapy, Then we need to have good knowledge about clinical, hospital, and community pharmacy. We need to develop skills and competencies in vaccine administration, vaccine management, clinical decision support systems. We need to collaborate with other healthcare workers like doctors, nurses, laboratory technicians, and practitioners of complementary and alternative systems of medicine. We need to focus more on prospective, preventive, proactive, promotive, precision, personalized, participative, people centered pharmaceutical care and healthcare. And we need to adopt, emulate, and integrate new age technologies like artificial intelligence, machine learning, this augmented reality, virtual reality, big data analytics, robotics, cloud computing, blockchain technology into the pharmaceutical education, research, and innovation. We need to impart skill and competency based education, undertake cutting edge, contextual translational research, innovation incubation, startup development, and we need to integrate omics and informatics based technologies with systems biology and quantitative systems pharmacology. We need to emulate, incorporate digital twinning for quick and precise new drug design. We need to retreat, renovate, take recourse in age old wisdom and traditional knowledge of integrative, holistic, and lifestyle medicine, which is embedded in our Ayurveda, which is embedded in our Unani and Ayush systems of medicine. So, lastly, I would request all the participants and listeners to take a pledge to further Atmanirbhar Bharat, Viksit Bharat, contribute significantly in this direction, and help our country, help our leaders to fulfill this goal of Viksit Bharat by the year 2047. Thank you very much for listening patiently. Thank you all.
Thank you so much, sir, for the truly insightful and inspiring session. Your perspectives have been given us a deeper understanding of the dynamic role of pharmacist and the future direction of pharmacy practices. Thank you so much, sir. Thank you, everyone, for joining us. Subratri. Good night.
Right. Thank you. Thank you very much. Thanks a lot, Ashish Singh ji. Thank you, everyone.